All right, so good afternoon again, everyone. Again, my name is Shane Mall, one of the medical directors for Palmetto GBA. This is our Jurisdiction J open meeting. Just to state the record, I've just started the recording of this open meeting in compliance with CMS. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting and consent it on behalf of Palmetto GBA. Just for housekeeping, if everyone that is not speaking could keep their phone on mute. The speakers will have 15 minutes. I will remind them at 5 minutes and then with 1 minute left, if needed, that time is running out. Now, the slides have been distributed to all the Palmetto GBA participants. If there's external participants that desire the slides, they will need to contact the speakers. So speakers, keep that in mind if you want to give out your contact information. Our first speaker on the agenda is Dr. Ron Blankstein. Is Dr. Blankstein on? All right, sir, if you're there, we can't hear you. Dr. Ron Blankstein. Okay, well, we can move on to our next one, and then we'll just circle around to him, unless I hear otherwise. If there's anyone on the call that has contact information for that, if they get in touch with him. So we'll move on. Dr. Campbell Rogers, are you on?
I actually just received an email from Dr. Campbell saying that his access code isn't working, so I'm going to email him back right now. And I'll also reach out to Dr. Blankstein.
Okay, great. Thank you. All right. Well, we can move on to our next one. If she is here, Dr. Sarah Reinhardt, are you on the call? Okay, well, we're striking out so far. So, again, we're just stand by for a minute because I know that at least Dr. Rogers will be on. So,
yeah, this is Dr. Rogers. I just was able to join. I'm sorry to be late.
Great, thank you. So this is Shane Mall. I think we've been in conversations before over this topic. So our first presenter is not on the call yet. So if you don't mind, if you would go ahead with your presentation, that would be great. The slides have been distributed to the Palmetto GBA folks. You have 15 minutes for your presentation. I'll remind you at 5 minutes if you take up that time, and then at 1 minute left that you're running out of time. But if you'd like to go ahead, the floor is yours.
Sure. Thank you very much, Dr. Mal. We very much appreciate the opportunity, and I'll try to refer to the slides by the first title on each, just so people can stay oriented as they're flipping through. The agenda slide, what we'd like to talk about and review is in the draft LCD indications and restrictions, and also to provide a brief review of the recent ACC and AHA guidelines. Before jumping in, I wanted to thank you and Palmetto for the opportunity to participate in this discussion. We will, of course, submit written comments that contain all of the points made herein. So as has been the case before. But again, we're very much appreciative. And if we go to the next slide, which has just the American Heart Association and ACC emblems at the top, I did want to talk briefly about the guidelines and to recognize Palmetto for the swiftness with which you've sort of seen these and incorporated them into some changes in the LCD as reflected in the draft LCD. It's really remarkably quick turnaround. The next slide, which has a 2x2 matrix on it, is a brief overview of how the guideline writers structured their approach to chest pain, breaking the full waterfront of chest pain into the 4 quadrants you see here: stable or acute, and then patients with suspected coronary artery disease or patients with known coronary artery disease, the latter being defined primarily as patients with prior myocardial infarction, prior stenting, prior bypass operation, that kind of thing. In all 4 of these, the guidelines recognize coronary CTA as class of recommendation 1, level of evidence A for the suspected coronary disease, and recognize CTA as 2A for patients with known coronary disease. And then for FFRCT, it was recognized in the guidelines as class of recommendation 2A for all 4 of these. And the reason I mention this is, as you'll see, some of our comments on the indications reflect this stable and acute verbiage that the guidelines used. If you go to the next slide, which has 3 sort of circles on the lower left, the key elements in terms of FFRCT and the guidelines are the recognition of its utility In stenosis defined by CTA from 40 to 90% diameter stenosis, as you can see in the call-out pasted on this page, and that FFR in these lesions can be useful for diagnosing vessel-specific ischemia and also guiding decision-making regarding the use of invasive coronary angiography. And it was recognized that the use of FFRCT may help clinicians to avoid false negatives, avoid false positives, and increase clinical clarity. If you go to the next slide, which has Palmetto, FFRCT, et cetera, at the top, this is simply a reciting of the indications currently in the draft LCD. And you'll see on the next couple of slides, there are a couple of areas here that we would propose minor wording changes to. The indications, I won't read through all of them, but these are just taken directly from the draft LCD. And then the next slide, which says at the top, considerations, RE indications, parenthesis 1, have highlighted a couple of aspects from that prior slide. Number one, starting at the top, is that it identifies intermediate risk patients with acute chest pain and no known coronary artery disease. The red is my addition to this in patients with stenosis 40 to 90%, et cetera, or intermediate risk patients with acute chest pain. And then if you go down below the first horizontal line on the slide, our suggested revision will be to include stable chest pain as well as acute, hearkening back to that introduction to the guidelines. The second is to potentially simplify by just combining both of the above scenarios into one indication, because once, this is important sort of nuance, once a CTA is done and a stenosis 40 to 90% has been identified, of course, then coronary disease is, quote, known, because it's known to the person who's done the CTA and has interpreted it. So the very bottom of the slide, the proposed revised wording, which would correspond to the guidelines, would be intermediate risk with stable or acute chest pain with known coronary artery stenosis from 40 to 90% on CTA. If you go to the next slide, which has the same title but parenthesis 2 at the end, there are two items. One is just a very simple, I think it may be just a typographical consideration, that the verbiage in this draft LCD, which is very slightly in this way only different from some of the other MAC draft LCDs, has a greater than or equal sign before the 40 to 90% stenosis. That's, of course, a range, 40 to 90%. So the suggestion would be that what's read on this slide would be removed. More importantly is the second point on this slide, which is that the wording at present says, not in conjunction with stress testing unless FFRCT was not high quality and an alternative study needed. The suggestion revision here is that the aspect of quality, which we'll talk about in a couple of slides, really reflects the CTA imaging itself and the quality of the CTA image, which is in fact a consideration at HeartFlow in whether or not we are able to provide an FFRCT analysis. So the CTA quality is of consideration. The FFRCT is not really of higher or lower quality. It's a little bit of a disconnect there. So the proposed revision would be all the wording the same, not in conjunction with stress testing, et cetera, unless the CTA was not of adequate quality for FFRCT and an alternative study needed. If you go to the next slide, which has considerations RE coverage guidance support paragraph at the top. Again, the text at the top is taken directly from the draft LCD. The red has been added just to make a couple of points, and in order, and these correspond to the numbers at the bottom of the slide, that, as discussed earlier, suggest to change the stable, in this case, to stable or acute, so there's consistency throughout the document and consistency, or concordance, I should say, with the recent guideline. The second is, if higher grade stenosis, this is I'm reading at the top, the second red section, if higher grade stenosis, i.e. greater than 90% are present, this study is not medically necessary. And then if you jump down to number 2 at the bottom, in prior discussions with MACs, including with Palmetto, the clinicians and we have clarified that that there are indications for FFRCT for lesions less than 90%, which may exist and coexist in patients who also have other lesions, perhaps in smaller vessels or whatever, a lot more severe than 90%. And that knowing the FFRCT for the stenoses less than 90% may be an important consideration in guiding management. And this also would be consistent with the guidelines. So our suggested revision to that second red highlight at the top is to revise it as written here, if higher grade stenoses, i.e. greater than 90%, are present and no other stenosis, 40 to 90% identified, the study is not medically necessary. The final points are, the third point, I should say, is that there's the third red point, lower grade stenosis less than 30% do not require additional confirmatory data. We simply would suggest revising this to less than 40% for consistency throughout with this 40 to 90% stenosis range. And then finally, the last red point, if extensive plaque is present, a high-quality CTA is unlikely and stress testing is preferred. We would suggest removing that last statement. We'll show you data in a slide or two, looking at data around CTA and Ffrct in patients with substantial plaque burdens. High plaque volume in and of itself does not necessarily impair CTA quality in a way that would preclude the ability to use this pathway for such patients. So if you go to the next slide, which is considerations, RE restrictions, 4 have been highlighted in red. First is prior placement as prosthetic valves. 5th is intracoronary metallic stents. 8th is prior pacemaker or defibrillator leads. And then finally, number 11 is the 50%, less than 50% stenosis identification. And we'll touch on each of these briefly in the slides that follow. So let me go ahead and do that. Let me dispense with the number 11 first. Actually, that's simply less than 50%. We would suggest revising to less than 40% for consistency across the LCD and with the guidelines. So the next slide, this gets into a little bit of literature around the indications around extensive plaque, pacemaker leads, valves, and so forth. First, around extensive plaque, the published data in patients with complex coronary disease using this pathway is becoming increasingly abundant. One of the primary references is listed on this slide, and we'll provide the references, of course, in our written comments. But this would identify significant plaque burden as not a reason to avoid coronary CTA necessarily. And we'll provide this, as I mentioned. The next slide, which says heart flow Ffrct incoming CTA image quality at the top, is meant to provide an introduction to what heart flow does when scans come in. The first thing that happens in our process is a consideration of image quality. And some of the specifics, which I won't go through in detail, are listed on this in this slide. Each scan is reviewed against a series of image quality metrics, and if it does not pass a predefined threshold for image quality, it is not, no heart flow analysis is completed. There is no charge for the case, and finally, an explanation is provided to the site for why the scan failed the image quality at heart flow, in the hopes that perhaps additional reconstructions can be provided or that future scans can be done with different technique, et cetera. So the reason I mention this is that when we think about artifacts induced, for example, by pacemaker leads or defibrillator leads or prosthetic heart valves, those artifacts impair image quality in some, but certainly not all cases, and therefore this image quality process, we believe, will identify patients, even those with, for example, pacemaker leads, in whom Ffrct analysis is possible. So to prohibit all of those patients would be an unnecessary restriction. The next slide, which I won't review, simply shows examples of good, satisfactory, excellent, satisfactory, and poor quality to sort of make it more visual what this inspection process is looking at, and to highlight that overall the acceptance rate is well above 90% across our real-world users. So finally, the last slide, which is number 14, talks about intercoronary metallic stents, the last of these restrictions I wanted to speak about. The current preclusion is against any intracoronary metallic stent. Our instructions for use, a copy of which is shown here, do not preclude all intracoronary metallic stents, but rather include very specific subsets, metallic stent present in the left main, or left main stenosis with stents in the left system, or 2 or more systems with metallic stents present. So we would suggest this restriction be revised to correspond to our IFU and enable access for Ffrct to patients with metallic stents who fall into the categories consistent with our IFU. So let me stop there. That's my last slide. Again, thank you so much for the opportunity to participate in this meeting.
All right. Well, thank you, Dr. Rogers. We appreciate your time and efforts there. Also, we will look forward to getting your comments. That comment period is open through April 2nd. And all those comments will be responded to in our response to comment document. With that, we'll see, did Dr. Ron Blankstein join? All right, how about Dr. Sarah Reinhardt?
Yes, I'm here.
Okay, great. Appreciate you attending. I don't think you were on at the beginning, so the slides have been distributed to the Palmetto GBA folks, and so we will be looking through them. In the future, hopefully we will have technology will work with us, and we'll be able to display them as you go through them, but we will be looking through them as you speak. We'll give you 15 minutes if you need that amount of time. If you're running late, I'll remind you at about 5 minutes and then with 1 minute left. So with that, I'll turn it over to you.
Okay. Well, thank you for the opportunity to speak today. Obviously, this is a topic that we are all very passionate about. So first and foremost, I'm a clinician. I'm a cardiologist. So I literally try to see how I can take imaging and guide patient decisions. I was asked to talk about and give demonstration of a couple cases which illustrate the points of why we're asking for revision in the coverage. So the first case is the value of Ffrct in a patient with severe stenosis on one coronary artery and a moderate stenosis in the other coronary artery. And I won't go through all of the case details, but in essence, this is a younger male, middle-aged male, with multiple risk factors. He's actually had a cerebral infarction in the past. So this is a high-risk patient, and his stress test he actually had was abnormal. It was probably diaphragmatic attenuation, and his cholesterol is actually at goal. He's on goal-directed medical therapy, and his insurance actually denied the initial left heart catheterization because of low probability and symptoms. And again, remember on that stress test that he had no ischemia, and he was actually approved for a CTA. If you look at this, his calcium score is quite low. It's 37. It's only at the 80th percentile. So if you were just looking at the calcium score alone, you wouldn't think that the probability of an obstructive lesion would be high. But remember, this is a 50-year-old who is high risk, who's already had a cerebral infarction. And what you see on this LAD is there's very complex plaque, and I outlined this in blue on the following slide. And you can see that cross-section. It's a very complex high-risk plaque with high-risk plaque characteristics that are associated with acute coronary syndrome. So if I were just looking at the stenosis, I would say that it is severe. However, when you look at the right coronary artery, there's another stenosis, which is mild to moderate in severity, but it also has high-risk plaque. So there's nothing prohibiting interpretation of these vessels. You know, there's not significant calcium, but you have a severe stenosis in one and a moderate stenosis in the other vessel. And in the left circumflex artery, there's only mild disease. So again, what we see on that heart flow analysis is it's clearly ischemic in that one vessel that we called severe. But again, the added information that this other lesion in the right coronary artery does not demonstrate any lesion-specific ischemia, despite those high-risk plaque characteristics, tells us it's safe to medically manage that. So when you take that patient to the cath lab, the interventionalist should know I need to intervene on the LAD, but I don't have to worry about doing a stress test on that patient or do anything else besides goal-directed medical therapy. So again, it streamlines care in the cath lab without doing extra layers of testing when you have information on both stenoses at once. And let's say this vessel was heavily calcified, that LAD, it still can be added information which can be extremely beneficial because those are the lesions we can overestimate. So I would say in the calcified vessels, I'm using this more and more on a daily basis. So if we look at the case 2, we're talking about the value of Ffrct in a patient with a metallic cyst and one coronary artery and 40 to 90% stenosis in another artery. So again, this is an intermediate age male, 51 years old. Again, he has family history, high blood pressure, high cholesterol, so he's intermediate risk. So he already had a stenosis in December of 2020, which was treated with a stent. I think this is important to note because this was a recent stent, so the likelihood of a problem with these drug-eluting stent technologies is fairly low. So most of the time we're not worried about any stent pathology. because a lot of times that neointimal hyperplasia only develops about 5 to 6 years out. He's on very good goal-directed medical therapy. But despite that, he has had significant symptoms, and they ordered a CT coronary on him. So you can see the native left circumflex artery only has mild disease. The stent is widely patent. So obviously there's no significant issue with that. But there had been mild disease on that cath. We can see there's minimal disease here, but you see this hazy lesion within the LAD. The nice thing with this technology is that I can look at the vessel distal to that, I can measure that, and we can also see the myocardium at risk. So number one, the question was, there's nothing that we're worried about in the stent, but what about the other vessels? So this hazy lesion was hemodynamically significant. We have a reason for this patient's chest pain, but if you look, there's only a small amount of myocardium at risk, so we can safely treat that medically, but it also gives that patient a reason for their chest pain, which is extremely important, because a lot of times this would not show up on a nuclear stress test because we have what we call apical thinning defects. And in the same way, when we talk about those cases, like one of the other physicians on the call or one of the other presenters stated, I am always worried on a nuclear stress test about balanced ischemia. So if you have 3-vessel disease or left main, this can actually help me be more predictive and know the ischemic disease burden whenever you have high-grade disease. So I hope that these cases help illustrate the points of why we're asking for those to be incorporated into your policy, and I'm happy to answer any clinical questions that you may have.
Yes, thank you. I appreciate that presentation. It's always great to hear from clinicians that are actually out there doing the work and presenting real cases. So I don't have any questions, but I'll open it up for any of the other CMDs or anyone else that has questions about these cases for Dr. Reinhardt. Okay, well, hearing none, again, I appreciate your time. And again, if there's any particular comments that you would like addressed, you can submit those to us, and we will respond to those comments. All right, with that, did Dr. Ron Blankstein join?
Yes, hi everyone, Ron Blankstein here. Sorry, I was a little delayed, but I have slides in case you guys all have those available.
Yes, sir. We have the slides. We've distributed them internally. We will go ahead and open up the floor for you for 15 minutes.
Perfect. Thank you all. Well, thank you for the opportunity to speak with all of you today. My name is Ron Blankstein. I'm a cardiologist at Brigham and Women's Hospital in Boston. I'm a professor of medicine at Harvard Medical School. I am the director of cardiac CT at my program, and I'm also a former president of the Society of Cardiovascular Computed Tomography. And on the second slide, just a background on the technology we're talking about today. So as a cardiologist, it is well known that invasive FFR is the reference standard that we use to determine if a lesion in the coronary artery is limiting blood flow. And this is an essential information that we use to decide if a patient requires a stent or at times bypass surgery. And the technology of FFR-CT allows us now to obtain this information non-invasively. So instead of putting catheters into our patients and doing a more expensive and a more risky procedure, we can non-invasively determine what is happening at the level of the lesion. Is it limiting blood flow? And that's FFR-CT. If we go on to the third slide, this slide just summarizes a handful of studies. There's plenty more that have been done showing the outcomes of what happens when we actually use information from FFR-CT. And if I were to summarize the big message here, is that we know that when we do FFR-CT and the lesion is not flow limiting, meaning that the FFR-CT is greater than 0.8, we know that patients will do very well on follow-up to the point that we now have safety data that tells us that if the FFR-CT is unremarkable, that patient does not need to proceed to invasive angiography, and they can be safely treated with medical therapy. And there's, of course, enormous economic implications here when we can identify patients who can defer invasive testing, which is obviously much more expensive. If we go to slide number 4 here, this is a study from one of my colleagues, Mark Rabat, showing information that we know from other studies as well, that CT can be used in combination with FFRCT to defer invasive testing. And I think another slide we have that did not come on here, but because of this information, FFRCT now is in the chest pain guidelines. So I will share with everyone that I was actually one of the authors of the recent chest pain guideline. This is the guideline put together by the AHA and ACC and all the imaging societies on how we evaluate patients with chest pain. And specifically in the guideline, we recommended that when patients have a 40 to 90% lesion by coronary CTA, that a FFRCT has a class 2A indication, meaning it's a useful test. Let me just pause there, before I go on, just if there's any questions. If not, I'll keep on going. Specifically, if anyone has any questions on either the chest pain guideline or any of the safety data on use of FFRCT. I'll keep going. On slide 5 is an example of how we would use FFRCT specifically for multi-vessel disease planning, and this is an important clinical scenario when we do an invasive angiogram and patients may have multiple lesions in various coronary arteries, and we want to know which lesions are actually the cause of their chest pain, which lesion would benefit the most from opening it, from coronary revascularization. And often, just because patients have multiple lesions, it does not mean that all of them need stents and all of them need to be intervened upon. So this technology is certainly very helpful at identifying the lesions that are more likely to benefit from coronary revascularization. On the next slide, 6, we see the proposed list of exclusions, and some of these are actually not necessarily established based on studies why it would be an exclusion. So specifically, for example, a placement of a prosthetic valve, just because a patient has a prosthetic valve, that would not affect the FFRCT values. We also know that when patients have a pacemaker or defibrillator, that should not be an issue either for patients who have that. So going on to the next slide, which I think is an important slide regarding what we think should be the recommended criteria. First of all, you do need good image quality to perform FFRCT, and HeartFlow has served as a very effective gatekeeper by only doing the analysis when there's acceptable image quality, and I think that's an important thing to continue that. We also want to exclude anatomy that would impact the accuracy of FFRCT, but having aortic stenosis or having a valve implanted would not affect the ability to both image the coronary arteries and do an FFRCT evaluation. Patients who had a recent myocardial infarction within the last 30 days, that's an exclusion criteria as well. And new systolic heart failure with no prior invasive angiography, so as well. So our recommendation is to remove the 2 exclusion criteria here, and that's prosthetic valves. Certainly no clinical rationale why they should be excluded, and also prior pacemakers in defibrillators. And that's consistent with the guideline, the range of stenosis to where FFRCT would be beneficial is 40 to 90%. I think that's the end of my comments, and I would certainly be very open to any questions on anything on my slides or anything else discussed at today's meeting.
All right. Well, thank you, Dr. Blankstein, and I'll pause here to see if any of the CMDs or anyone else has any questions for you. All right. Well, hearing none, again, we appreciate all the participation. We appreciate everybody's time on the call. We do encourage, if you have any particular questions that you want addressed, either that was discussed today or just regarding either of the policies that we're covering in this open meeting, that you send those comments to a.policy@palmettogba.com. That comment period will be open to April 2nd. So with that, I appreciate everybody's time, and have a good day, everyone.